Be true in the majority of, and in this lecture we're going to look at how to assess the shape of the gallbladder. The gallbladder is described as being an oval or pear-shaped structure, and while that may be true in the majority of cases, there are quite a few normal variants that need to be recognized by the sonologist. When the gallbladder fundus folds on itself, it is referred to as a pharyngean cap. Here you can see a sagittal view of the gallbladder here, and you can see that there's a fold up by the fundus here, and here you can see the body heading down towards the neck on this sagittal view. These gallbladder folds may mimic septations, but it should be possible to demonstrate a change in the outer contour of the gallbladder. You can see that there is a change in the outer shape of the gallbladder due to this pharyngean cap. And with septations, you normally maintain a fairly normal outer contour as opposed to the change in the contour that you'll see with the pharyngean cap. In this sagittal video, note the presence of a pharyngean cap here. You can see the change in the outer contour of the fundus of the gallbladder. You can also see that there's a stone trapped within this pharyngean cap. You can see the clean shadowing posterior to it, but you can see here's the body. Here up by the fundus is the pharyngean cap, and there's the large stone trapped within it. This is a contracted gallbladder in a patient who had recently eaten. This is a sagittal view. You can see here's the right portal vein, here's the main lobar fissure, here's the contracted gallbladder. There still is some bile seen within the lumen here, but you can also see up by the fundus that there's a fold and a change in the outer contour, and that's due to a pharyngean cap. Frequently, folds are seen in the region of the gallbladder neck. These are of clinical significance since these folds can provide locations where the gallstones can be trapped. In both of these images, the typical fold are seen near the gallbladder neck. So you want to keep an eye out for these because these are areas where stones can then subsequently get trapped. Here's a sagittal video clip of the gallbladder, and you can again see the fold down here by the neck. And like I said, it's essential that the gallbladder neck is fully evaluated since this is where symptomatic obstruction will occur. Visualizing this area may require gentle rotation and or angulation of the transducer, but it is essential that this area be evaluated. But you can see there's a fold down by the neck right there. We'll look at it one more time. There's the fold right there. Septations are rare. They generally appear thinner than folds, and they separate the gallbladder into segments that communicate then through a small pore. Note the presence here of internal septations in both of these gallbladders. Note that the outer contours of the gallbladders in these images are not significantly changed. Remember in the patients that had pharyngean caps, you saw significant change in the outer contour, but you really don't appreciate that here. This can be a way to differentiate septations from folds. Now this concludes the Assessing the Gallbladder Shape video. It is essential that you learn to identify these normal variants, particularly in the neck since this is where pathologic obstruction occurs. Work on developing the hand control skills early to aid in visualizing the gallbladder neck. Remember, this will frequently require gentle transducer rotation and angulation, but these skills are essential. I'm Dr. Robert Jones, and in this lecture we will be going through how to assess gallbladder size. The normal gallbladder is less than 10 centimeters in length on the sagittal image, and it's less than 5 centimeters in diameter on the transverse image. The measurements are obtained from outer wall to outer wall. The presence of gallbladder distension, particularly on the transverse image, suggests the presence of obstruction. However, as will be discussed in future lectures, size alone is a non-specific finding. Now, the sagittal measurement is less reliable than the transverse measurement for the detection of obstruction. It is not uncommon to see a very long, thin gallbladder with normal transverse width that exceeds the 10 centimeter upper limit of normal. If the dilatation is pathologic, then loss of the normal tapering by the neck and development of an elliptical or rounded shape should be noted. In this image, the sagittal measurement is obtained from the fundus down to the neck, from the outer wall to outer wall, and it barely exceeds the upper limit of normal. However, note that there's still the nice normal tapering down by the neck here. This was a patient with a normal gallbladder. The gallbladder shown here had a sagittal length measuring 11.4 centimeters. Note the presence of an impacted stone in the neck of the gallbladder. Due to the pathologic obstruction, note the loss of normal tapering down by the neck and the presence of a rounded shape due to that. And here you can see on the video clip again the loss of the normal tapering down by the neck, and note that it has a more rounded shape, and there's also some gallbladder wall thickening noted also. The gallbladder here has a normal sagittal length. It measures 8.66 centimeters, which is less than the upper limit of normal of 10 centimeters. This patient was found on further scanning to have 2 obstructing stones in the common bile duct with evidence of both intra and extrahepatic ductal dilatation. So the take-home point here is that normal measurements do not exclude the presence of pathologic obstruction. You can see within the lumen here multiple small stones with shadowing, and you can see gallbladder wall thickening is present also. The transverse measurement is obtained again from outer wall to outer wall at its widest point in the fundus. The normal gallbladder is less than 5 centimeters. The presence of dilatation on the transverse measurement seems to correlate better with the presence of obstruction, but again, it is a nonspecific finding. The absence of dilatation does not rule out obstruction. Now here are 2 gallbladders that were obstructed due to the presence of a stone in the neck. Both gallbladders measured outer wall to outer wall exceed the 5 centimeter upper limit of normal. These patients both had cholecystitis. The gallbladder here has an obstructing stone in the neck. You can see that the gallbladder is distended. It measures just under 6 centimeters at its maximal transverse width, so it is dilated, and this was a patient with acute cholecystitis. Let's review some key points before concluding. Gallbladder enlargement is suggestive of obstruction, but is a nonspecific finding. The sagittal length of a gallbladder should be less than 10 centimeters. The transverse width should be less than 5 centimeters. Transverse measurements correlate better with obstruction than do sagittal measurements. However, and this is important, the absence of gallbladder enlargement cannot be used to rule out the presence of obstruction. This concludes the assessment of gallbladder size video. I'm Dr. Robert Jones, and in this video we're going to be assessing the gallbladder lumen. Here is a transverse sweep through a normal gallbladder. The lumen will be anechoic in the normal gallbladder. Note that there's the absence of any internal echoes within the lumen of this gallbladder. You can see this on the full sweep here. It's completely anechoic. You can see the nice walls surrounding it here. Here is a sagittal sweep of a normal gallbladder again. Note the absence of any internal echoes. Note in the near field, however, the presence of reverberation artifacts. You can see these up in here within the lumen. These are very common and should not be confused with pathology. Now here's a normal gallbladder. The gain, however, is set too high, so there are some artifactual echoes noted within the lumen, but these also should not be confused with pathology. Reverberations are also again seen in the near field here, and like I said, these are common artifacts, particularly in thin patients with relatively superficial gallbladders, but you do not want to confuse this with pathology. Now, gallstones will appear as echogenic, mobile, unless impacted, intraluminal structures that cast echogenic shadows. The shadowing occurs due to sound beam absorption by the stones. Demonstration of shadowing, as you see here, is an important criteria for the diagnosis of stones and can be used to distinguish stones from polyps as well as sludge. Note in this image here the presence of multiple echogenic stones within the lumen with clean posterior shadowing. When stones are visualized, the gallbladder exam must be performed in two positions in order to document mobility of the stones. Also note on top of the stone here you have some tumefactive sludge, which we'll be going over later. Here you have three large echogenic stones with posterior acoustical shadowing seen on this sagittal image. The stone on the left was impacted in the neck and did not move when the patient changed positions. This was the cause of the patient's pain. Now, multiple small stones are seen on this image. You have posterior acoustical shadowing behind all the stones except for the one on the left. Note that stones less than 3 millimeters, and this stone was 2.9 millimeters, may not shadow. It's important to use the highest frequency possible and set your focal zones at the level of the stones in order to maximize the chance of documenting posterior acoustical shadowing. Using a lower frequency setting and having incorrectly set focal zones may lead to lack of shadowing for stones larger than 3 millimeters, and this may cause you to not diagnose a stone when there was one present. Now, the use of tissue harmonics can improve visualization of posterior acoustical shadowing. In the image on the right, shadowing can be seen, but it's not as crisp. In the image on the left of the same patient, tissue harmonics was used, and it can be seen that the stones are better visualized and that the posterior acoustical shadowing is crisp. You can see this nice clean shadowing behind the stones here. In difficult cases, the use of harmonics should be considered. Multiple echogenic stones are seen within the lumen of this gallbladder with posterior acoustical shadowing. You can also again see reverberation artifacts in the near field, which should not be confused for pathology. This patient was repositioned in the left lateral decubitus position to document stone mobility, and all the stones were found to be mobile. A contracted gallbladder is present here, making the ability to see the gallstones more challenging. The absence of surrounding anechoic lumen filled with bile makes the diagnosis more challenging, even for the novice, particularly for the novice scanner. However, note the presence of posterior acoustical shadowing here. This is an important artifact when evaluating the gallbladder for gallstones. You can see if you look real close, there's a gallstone. There's several small ones right here. But if the gallbladder was more distended, these would be easier to distinguish. So keep that in mind when you're scanning these unprepped ED patients. The gallbladder is noted in both sagittal imaging on the left and transverse imaging on the right. And you can see here on the sagittal view that there's multiple echogenic foci with posterior shadowing within the lumen, consistent with gallstones. And you can see here on the transverse view again, multiple echogenic foci with clean shadowing. This patient had multiple gallstones. Therefore, this patient was placed in the left lateral decubitus position, and all the stones were noted to be mobile. As I've said, it's really essential that the gallbladder neck be visualized. This sagittal clip was obtained by a novice scanner, and they felt that it was an adequate scan of the gallbladder. However, the neck was not completely visualized, and this was a patient who did have a sonographic Murphy's. By just gently angling the transducer in this patient, the neck was better visualized and an impacted stone was identified in the gallbladder neck. Transverse scanning through the gallbladder neck can also be performed to better visualize the neck, but this patient was moved into several different positions and this stone stayed fixed there, So this patient ultimately went on to have cholecystitis and underwent lap chole. In this patient who has a large solitary stone within the lumen of the gallbladder, you can see the three arc-shaped lines of the West complex, which stands for wall, echo, shadow. This is usually seen in patients who have gallbladders filled with stones, as in this case. Now keep in mind that the gallbladder maintains an intimate relationship with adjacent bowel. Here is a case where air within the bowel mimicked the appearance of gallstones. If you look first at the sagittal image here, with it frozen, you see these echogenic foci, but behind it you do not see clean shadowing, you see dirty shadowing. On real-time imaging, you can note that there's peristalsis present, which is what you would expect in normal bowel. So it's really important that you look for the appearance of the clean versus dirty shadowing, since this can help you in the diagnosis of gallstones. Here you have a sagittal view of the gallbladder, and you can see that you've got both clean shadowing here from stones, and you've got dirty shadowing from adjacent bowels. So remember, differentiate clean shadowing from dirty shadowing, since this has a significant clinical utility. The clinical significance of sludge is not entirely clear. Frequently, it is seen in hospitalized patients or in patients receiving hyperalimentation. Sludge consists of calcium bilirubinate granules and cholesterol crystals and localizes in the dependent portion of the gallbladder and forms a bile sludge level. The sludge is echogenic but non-shadowing, and the sludge is mobile. In this patient, you can see that there is a bile sludge level on the transverse image, as well as a bile sludge level on the sagittal image. Note how the sludge is essentially isoechoic to the liver parenchyma, and this could make identifying the gallbladder more difficult, particularly if this gallbladder had been completely filled with sludge. Now this patient has both sludge and cholesterolosis. Note you can see the echogenic area within the dependent part of the gallbladder here on both the sagittal view here as well as on the transverse view right here. This represents gallbladder sludge. You can also see multiple echogenic foci in the anterior portion of the gallbladder. This is due to the presence of cholesterol crystals. Sludge may form mass-like aggregates called sludge balls or tumefactive sludge. This patient has a large sludge ball seen occupying the lumen of the gallbladder. Now here's a 44-year-old male who presents with right upper quadrant pain, status post-liver biopsy. Gallbladder ultrasound reveals that there is an echogenic foci within the lumen, which is mobile and non-shadowing. While sludge would be in the differential, this patient had hematobilia related to the procedure. Remember, ultrasound cannot distinguish between the two. This is the same in soft tissue ultrasound, where the sonographic findings of hematomas and abscesses will be identical. But this patient had hematobilia due to his recent liver biopsy. Now, the primary goal in the management of gallbladder polyps is to prevent the development of gallbladder carcinoma. Polyp size has long been known to be the simplest predictor for malignant potential. Recent studies suggest that cutoff size should be 6 millimeters as opposed to the traditional 10 millimeter recommendation. Age greater than 50 years of age and the presence of a solitary polyp are considered other important risk factors. Patients with gallbladder polyps greater than 6 millimeters who are at risk for gallbladder carcinoma should undergo cholecystectomy. The natural history of small polyps less than 6 millimeters in size suggests that they can be confidently monitored with serial imaging. But here you can see on this transverse scan, in the non-dependent part of the gallbladder, you have two echogenic foci without posterior shadowing. These are non-mobile, and these represented two gallbladder polyps. Now, this patient was found to have multiple gallbladder polyps on the gallbladder exam. The largest polyp measured about 8 millimeters. This patient subsequently underwent cholecystectomy, and the polyps were all found to be benign. But you can see here that there's multiple echogenic foci. There's no posterior shadowing. These are non-mobile, and you can see that a lot of these are in non-gravitational regions. Emphysematous cholecystitis accounts for less than 1% of all cases of cholecystitis. As many as 40% of patients who have this are diabetic. The condition can be recognized on ultrasound exam by the presence of echogenic gas with posterior reverbs located in a non-dependent location. This patient with emphysematous cholecystitis has multiple echogenic foci anteriorly with posterior reverberations. And here you can see the correlative CT scan showing air within the lumen of the gallbladder. This is a diabetic male with right upper quadrant pain who has emphysematous cholecystitis. Note the presence of the echogenic foci with posterior reverberations. This has the dirty shadowing appearance that you would expect with air, and you can see the same thing on the transverse scan. What you can interestingly note on the transverse scan also is that there are echogenic foci moving in a non-dependent direction, which is consistent with the presence of gas bubbles within the lumen. This patient underwent emergent cholecystectomy. But again, notice the presence of the echogenic foci anteriorly and the reverberations. This concludes the Assessing the Lumen video.